Assalamualaikum candidates. I'm Dr. Nadia, gynaecologist and online teaching mentor. We are discussing thyroid disease in pregnancy. Either it can be hyperthyroidism or it can be hypothyroidism. Now, it is the most common endocrine disorder in pregnancy, affecting about 1 to 2% of the pregnant women. Hyperthyroidism is most commonly seen in Graves' disease, as in 90% of the cases, and hypothyroidism affects about 0.05% in cases. And also in postpartum thyroiditis, the incidence is about 5 to 10%. So, now coming towards the introduction, is that thyroid gland is basically having two lobes. So you see here it is a comprising of two lobes, and central isthmus is the part, and basically this weighs about normally 15 to 20 grams. So ultimately the development in the fetal line, if general we discuss it, is that fetal it arises as forms as a midline outpouching of the anterior pharyngeal floor and migrates and reaches its final position by about 7 weeks, and then little contributions arise from the fourth and fifth pharyngeal pouches and give its bilateral shape by about 8 to 9 weeks gestation. So what happens that the basically the hypothalamic pituitary axis governs the thyroid gland, the thyroid physiology. So hypothalamus produces thyrotropin releasing hormone. This thyrotropin releasing hormone acts on the anterior pituitary and ultimately produces the thyroid stimulating hormone. The thyroid stimulating hormone in turn acts upon the thyroid gland, and ultimately by this activity there is an increased production of T3 and T4. So ultimately once the production, then basically the production of the thyroxine is regulated by intake of the iodine, and basically it depends upon the iodine that is being transported to the thyroid gland, and iodide is incorporated into the thyroglobulin, and ultimately by this the thyroxine T3 and T4 enters into the circulation. So what happens that normally there is an increase in the thyroid gland, 20% increase in thyroid gland size due to hyperplasia and increased vascularity. Similarly, there is an increase in estrogen and also increased thyroglobulin binding globulin, and there is decreased free D4 and HCG level rises. Now what happens if there is a rise in the level of beta HCG? Then basically the alpha subunit of beta HCG has got a thyrotropic activity, and it attacks upon the thyroid gland, and ultimately it leads to an increased production of thyroxine. So ultimately what happens that in the early pregnancy there in most of the cases there is an increased activity of the thyroid gland. So ultimately T3 and T4 might be increased and TSH level is decreased, and the TSH level is decreased because of the compensatory reduction. Now what happens regarding the antenatal management? The pre-pregnancy management of the thyroid gland during antenatal visit: check for the thyroid function tests if the history is suggestive in the patient. So we have to examine the thyroid, and we have to take history, we have to inspect it, we have to see the swelling, the site size, shape, and the margins, the surrounding skin, the visible pulsations, the scar marks, and also hands and tremors. The eye signs should be seen, and palpitations should be assessed. Also we have to examine the neck from the front and from the back, and we have to see the retrosternal extent of the thyroid gland by asking the patient to raise the hands, and in this way if there is stridor or there is difficulty in breathing, then we should expect that there is possibility of a retrosternal extent of the thyroid gland. So then we will definitely go towards percussion and auscultation, and knee signs, knee jerks will be also be evaluated. Now in as I've told that in hyperthyroidism, what happens that it's seen in about 0.2% of the pregnant women, and in most of the cases it's about uh, 95% of the cases it's because of Graves' disease. So what happens in the Graves' disease? Basically, the stimulatory antibodies, they are produced, and ultimately they go to stimulate the thyroid gland, and ultimately what happens that T3 T4 levels, they are increased, and because of increased T3 and T4 there is compensatory decrease in the level of thyroid stimulating hormone. So there will be increased in the levels of T3 and T4, and free T4 level will be increased in the circulation. So what happens if thyroid levels, they are increased during the pregnancy? So these are the sorry, maternal risk and the fetal risk. So regarding the maternal risk, what happens that increased thyroxine in turn leads to increased basal metabolic rate in the female. So this in turn leads to an increased tendency of heart failure. Thyroid storm can be there in case of stress, in case of surgery, in case of any illness. And similarly, the risk of preeclampsia is increased in 11% of the cases as there is increased uh, um, uh, catabolic activity going on inside the body. So ultimately the patient is prone to have psychosis, seizures, coma, and their fibrillation, atrial fibrillation can be there, and also preterm loss can be there. She is more susceptible to have anemia. And regarding the fetal risk, there can be fetal tachycardia as well, because the fetus is also exposed to hyperthyroidism environment, in a way that the thyroid T3 T4 levels, they are raised, and ultimately the fetus might develop intrauterine growth restriction. There can be even intrauterine fetal death can be there. There can be some poor weight gain, feeding, jaundice, hepatosplenomegaly, and there can be jaundice in the fetus as well. There can be fetal goiter as well. And the hyperthyroidism, generally the features are like in case of increased basal metabolic rate. So patient will be intolerant to the heat, and also there will be bulging eyes if there are eye signs, and there will be flushing, there will be enlarged thyroid gland, tachycardia in the heart, and even atrial fibrillation might be assessed, and there might be weight loss in the patient, and also excessive muscle wasting is there, and also tremors, diarrhea, menstrual changes if she is before pregnancy she might experience. And then what is the management? So the management is very important in the patient. The management is that you have to make the patient euthyroid in such a way that we have to manage the thyroid levels in such a way that we have to keep the levels in the euthyroid range. And so what happens is that we have to give the anti-thyroid medications in such a way that we have to suppress the levels of T3 and T4, and these are the drugs these are named as propylthiouracil and carbimazole. So the propylthiouracil and carbimazole, basically they both cross the placenta, and they are not teratogenic. However, what happens that propylthiouracil, basically it's excreted from the liver. So we avoid it in a way to avoid maternal hepatotoxicity. And also the important thing is that the propyl thiuracil is comparatively less teratogenic as compared to methimazole. Methimazole may lead to an increased risk of atresia, esophageal atresia. So ultimately, we put the patient on methimazole in the second and third trimesters, and in the first trimester we give the patient propylthiouracil, but in the late trimesters we do not give the patient propylthiouracil because it has the risk of hepatotoxicity. So ultimately, along with this anti-thyroid medication, we have to monitor the thyroid function test 4 to 6 weekly. Why? Because the medication takes about 6 weeks to have an effect. So that is why we go for the thyroid function test about 4 to 6 weekly. And also, if the patient is having tachycardia, then we will give the beta blockers. And also, if, for the tremors and palpitations, and surgical removal is rare, and she may undergo develop thyroid storm, and is in case of stress, in case of surgery, which is actually in case of hyperthyroidism, when there is acute release of excessive thyroxine in the circulation, and that this in turn can lead to a crisis in the patient. And so regarding the dose of carbimazole, the dose is 15 to 100 milligrams daily, administered in 3 divided doses. And also the dose of the propylthiouracil can range from 300 milligrams daily to a maximum of 1200 milligrams daily in the 3 divided doses. And also once the serum thyroid levels they return to normal, it is necessary to decrease the dosage by 520 milligrams daily to or carbimazole. And ultimately, when doses of propylthiouracil are more than 300 milligrams per day or more than 20 milligrams per day for carbimazole are taking long term, fetal goiter and hypothyroidism may result. Why? Because these medications, as we have discussed, that they cross the placenta. So if they cross the placenta, then ultimately this will result in fetal hypothyroidism, because these medications are going to control the thyroid levels of mother, but if they cross the fetal circulation, then this will result in fetal hypothyroidism. So we have to be very much vigilant regarding this medication. Now then coming towards hypothyroidism, it occurs in about 1% of the pregnant women and is mostly seen in case of Hashimoto's thyroiditis. What is it? Actually, these are the inhibitory antibodies which ultimately suppress the function of thyroid, and ultimately as a response of this, the thyroid stimulating hormone will be increased, and ultimately in subclinical stage the T3 T4 they might be normal, but in case of hypothyroidism, frank hypothyroidism, T3 and T4 they will definitely be reduced and TSH will be increased. So occurs in about 2 to 5% of the cases, and it is associated with gestational hypertension, preterm delivery, stillbirth, and even abruption may occur. So in the fetus there can be psychomotor cognitive defects in the fetus, and also in this case the signs are that in the patient is usually intolerant to the cold and is having there is a loss of outer one third of eyebrows and also hair of the eyebrows, and also there can be even there can be hair loss, and also slow slurred speech, brittle nails, and also the patient will be experiencing bradycardia. There might be weight gain, thickened skin, cardiac complications can arise, and also the patient is liable to have is prone to have constipation, and also muscle weakness, dry coarse skin, and also the slow going ankle jerk is there in this patient of hypothyroidism. So what are the fetal maternal effects on the pregnancy? The effects are prolonged infertility, subfertility in the patient. Why? Because basically what happens is that because of hypothyroidism, once the thyroid stimulating hormone is produced, so it also induces the release of prolactin. So prolactin basically produces amenorrhea, endometrial thinning, and also ultimately there is ultimately an ovulation, and this will result in subfertility. So also there is recurrent risk of recurrent abortions, preeclampsia, abruption, preterm delivery, and myxedema coma because of hypothyroid condition. Malpresentation might be there, and stillbirth and low birth weight might be there. Similarly, we have discussed that on the fetus, definitely that the fetus is liable to have a neurodevelopmental delay, cognitive defects, stunted growth, and also the neonatal mortality. So management is definitely we have to administer thyroxine, levothyroxine, sodium 1 to 2 micrograms per kg per day should be given, and it is given in empty stomach, and it steadily we increase the dose, and we measure then the thyroid stimulating hormone by about 6 to 8 weeks, because we know that thyroid stimulating hormone takes about 6 weeks to be regulated. So we monitor it by 6 weeks, and also we have to give levothyroxine to the patient immediately, and ultimately this medication, the levothyroxine dose needs to be adjusted. So postnatal management is that care of the neonate, ultimately breastfeeding, and watch for the signs symptoms of the maternal worsening. So if the mother is hypothyroid and you are giving thyroxine to the patient, so definitely what you have to do is that you have to monitor the fetus for any signs of hypo or hyperthyroidism. And also if there are stimulatory or inhibitory antibodies, they take about few weeks to clear off. So ultimately during that time we have to monitor the antibody levels in the fetus as well as the thyroid function test, so that once they are regulated, then we definitely reassure the patient. So other is the postpartum thyroiditis occurring post pregnancy, post delivery, and it is an inflammation of thyroid occurring after the birth of the baby, occurring in about 5-10% of the cases. And in this case what happens is that it might, the patient who is having autoimmune disorder or having positive antithyroid antibodies or any history of previous thyroid dysfunction or postpartum thyroiditis, in 20% cases there is a recurrence risk or any family history of the thyroid dysfunction. So how it is treated, basically it's because of it's an inflammatory disease, so definitely we have to give the patient anti-inflammatory drugs. And also if she is having tremors, we have to give or palpitations, we have to give the beta blockers. And antithyroid medications are not used for thyrotoxic phase, since the patient is this thyroid is not overactive. And also we have to monitor the dosage of the thyroid hormone. And ultimately once the patient becomes euthyroid, then we have to taper the dose ultimately. So this was all about the thyroid disorder in the pregnancy. And we have discussed that propylthiouracil and carbimazole, they both cross the placenta, and ultimately if the mother, she is a hyperthyroid, then fetus is at risk of hypothyroidism because of the medication. And similarly the stimulatory or inhibitory antibodies are also are going to act upon the fetus. So once the baby is delivered, you have to monitor the antibody levels. And also I've discussed the very important point that in 90% of the cases the hyperthyroidism is because of Graves' disease. And also in where the stimulatory antibodies are produced and ultimately produce an increased activity of thyroid gland, leading to increased levels of T3 and T4. And also as far as hypothyroidism is concerned, then in Hashimoto's thyroiditis is the most common, where actually the inhibitory antibodies are produced which inhibit the activity of thyroid gland, as a result of which the thyroid stimulating hormone from the anterior pituitary circulation is increased. And it is also causing an increased release of prolactin, because of which subfertility is also a concern in case of the hypothyroidism. So this was all about the thyroid disorders in the pregnancy. Thank you.